So good afternoon, everyone, and welcome. Thank you for joining us for today. For those of you who haven't met before, my name is Michelle, and I'm the marketing manager here at INNEG. So thank you for joining us for today's webinar on Cauda Equina and spinal cord compression. Before I introduce today's speaker, I'd just like to briefly explain what we do here at INNEG. We help solicitors identify and instruct the right expert witnesses for complex clinical negligence and personal injury claims. If you'd like to learn more, please do head to our INNEG website where you can explore our expert panel. I'm now delighted to introduce today's speaker, Mr. Nikolaos Tzerakis, who is a consultant neurosurgeon and spinal surgeon with over 20 years of clinical experience and more than a decade of medical legal practice. He regularly provides expert opinion on breach of duty, causation and prognosis in complex spinal claims, including Cauda Equina syndrome and spinal cord compression. Nikolaos, thank you very much for joining us today. I'll hand over to you.
Thank you very much for the kind introduction. I am Mr. Tzerakis. I'm a consultant neurosurgeon. My primary work in neurosurgery and primary scope is spinal surgery, but I have a vast experience in other parts of neurosurgery, including vascular surgery. Our today's meeting is mostly around the spinal problems that we see on everyday spinal practice. And this includes primarily the Cauda Equina syndrome, which is a very important syndrome. We'll see later on how much effect it has on the claims, number of claims, and the significance it plays in the general treatment of the patients. But also regarding the spinal cord pathologies, which might be missed and might create another claim. So we'll try to explain what Cauda Equina is, although there is no specific definition of that, and also how the spinal cord compression might present. We'll touch upon some historic data. We'll mention about the significance of this medical condition. What do the doctors should do when they come across patients with suspected or established Cauda Equina or spinal cord compression, and the common causes of failures and the causes of claims in this process. Very brief anatomy, just to understand what we're looking at. This is the lower back, the lumbar spine, 5 bones, big bones, the vertebrae. We can see on the side that there is always one nerve escaping from the spine, merging with the others, that creating the sciatic nerve. That's what the term sciatica comes from. If we go there and we open the lining of the spinal cord and the nerves, we can see the nerves, how they are arranged in the lumbar spine, and they look like a horse's tail. And the Latin term for the horse's tail is Cauda Equina. This is where this term comes from. Spinal cord. The spinal cord is the main fiber optic of the nervous system. In a very small space of around a couple of centimeters, we have there all the function for the arms and the legs, depending on the level of the spinal cord. Fibers going up and down the spine and regulating the function of the arms, the legs, and the internal organs. Any potential harm in those areas can cause some specific problems, and depending on the location, we have the relevant clinical picture. The bladder is main part of this presentation because this is one of the organs which are the targets for this pathology, the Cauda Equina and the spinal cord. Effectively, and without tiring you with many medical terms, the bladder can be voluntarily be controlled, but also 2 main systems which are outside of our direct control play a specific role in the management of the bladder function. And this is the sympathetic nervous system, which allows the bladder to full with urine, and the parasympathetic system, which allows the muscle of the bladder to contract, and another one which is lowered down the sphincter of the bladder to relax, so we can void the bladder. To remember, the parasympathetic is the one that allows the patient to pee. So that's how we remember the parasympathetic allows the emptying of the bladder. How do nerves get in trouble when we have Cauda Equina syndrome and generally when we have compression? The most common pathology is what we see there on the screen. This is the disc, the pillow between the bones of the spine. As every pillow, it has this pillowcase, which is the annulus, and the inside bit, which is the nucleus pulposus, something like gelatinous stuff, something gel stuff. Depending on the degree of protrusion of how much of this material has come out and if the pillowcase is intact or not, we have different grades. A simple bulge is when we have intact the annulus, so the pillowcase is still in place, a bit weaker but still in place, and we have some protrusion of this, some bulging of this material, so the material goes towards the nerves, but not significantly. The protrusion is when the annulus has almost completely open, so more material can come out. The extrusion is when we have the opening of the pillowcase of the annulus, so part of it has come out, but still connected with the main disc. And the sequestration is when we have a piece of the gelatinous material coming out and disconnected from the main disc. This is important. We'll see later why about the Cauda Equina syndrome. So, is there a specific definition? There is no agreed definition, this one. People mention different definitions regarding that, but clinically speaking, when we see a patient, we suspect that this is in place when the patient complains of problems with the bladder and bowel, what we call autonomic problems. And in combination with that, we have some numbness around the area of the buttocks and the inner thighs, where the body would touch a sella of a horse. That's why it's called sella anesthesia. So effectively, when we use the word syndrome, means that this condition can have a similar clinical picture, as we said, autonomic dysfunction, bilateral leg pain, acute bilateral leg pain, or numbness in the sellar area, so this clinical picture, but different causes as opposed to a disease which has one cause. So syndrome, many causes for the same condition, disease, one cause. It is a very rare syndrome, only 1 to 3 patients in 100,000 population, but still very, very important. This is the clinical picture that I described before. So when the patient comes to us, they complain of some bladder and bowel dysfunction, possibly for some sexual dysfunction and some subtle anesthesia. We see here the area that would expect to be involved, particularly because it's not always full-blown picture, particularly around the area of the anus. This has to be documented as the examination when we see a patient in the clinic. This paper has clarified and classified some forms of the Cauda Equina syndrome because the clinical pictures are never fully expressed and manifested as they are in the books. So in this picture, we have a classification in some different conditions, some different forms of the Cauda Equina syndrome. The one is suspected, the other is incomplete when we don't have the full clinical picture. The Cauda Equina with retention, so the patient is unable to pass urine, and the complete Cauda Equina syndrome, the patient has developed incontinence and fully lost the function of the area. The suspected is when the patient comes to us and they're complaining of acute bilateral leg pain or some dysuric symptoms, not very clear picture of something going with the bladder, but they also say that they have some symptoms around the area of the saddle area that we saw before, the perineal region, as we call it. And it might be that on our examination, we don't find any obvious Cauda Equina syndrome findings. So we examine the patient, don't find anything obvious. We examine the sensation, we ask the patient to squeeze the finger with the anus, and things are there. But still a patient has a picture that points towards a problem in the lower back that might cause pressure on those nerves. In this situation, we have to do an urgent imaging, and if it is confirmed, then we have to proceed to an operation to avoid the progress of this condition to the more important conditions like the incomplete Cauda Equina, when we have also objective findings with numbness in the area or changes in the tone of the sphincter of the anus. The patient might have lost more control of the bladder. And if the patient has the incomplete Cauda Equina syndrome, they might have some voluntary control, so they might be able to pass urine. So the test that we say sometimes, let's say if the bladder is empty, is not 100% excluding of the Cauda Equina syndrome. On the contrary, the patient might have the syndrome despite being able to pass water. If we do that, then we avoid the progression to the next stage. Long term, the patient might have typically a socially normal bladder and bowel control. That means that they can retain an amount of 400 ml in the bladder. They might go more often or in regular time spaces to the toilet, but they generally are having the capacity to function within the social environment. However, many of them do develop sexual dysfunction. The retention, obviously, we have the bladder is not sensitive anymore. They cannot feel they have a lot of urine in their bladder. We check with a scan or with a bladder scanner or with a catheter. We see more than 200 ml of urine in the bladder. And despite that, they can still improve after an operation. So it's still a condition that can still offer an operation as an urgency. But if we see at the long term, only a minority of patients can go back to the pre-Cauda Equina syndrome condition. And it is the question if the operation has to be done urgently or not. Myself, in my practice, I always try to do it as early as possible for the reasons that we see here, that 40 to 93% of the patient has some improvement. So nobody can tell that you shouldn't be doing it as urgently. The spinal cord compression is a bit a different situation. The clinical picture is a bit different, although the patients might present with a similar pathology, with some dysuric symptoms. And this is where the most of the problems happen, because sometimes people scan only the lower back, they find nothing, they say you can go home, nothing for you to be done. But as we will see a bit later, there are cases that have been missed because the patient had the pathology higher up and they haven't scanned the patient appropriately. And this might include spinal cord compression from cancer or a disc prolapse, which is rare in the thoracic spine or in the neck, but it might happen, an abscess infection, or other conditions like hematomas. This might cause weakness and paralysis. Generally speaking, when a patient comes to us with sudden anesthesia and bladder symptoms, we are mostly suspecting the Cauda Equina syndrome. But if they have weakness in the legs and sensation problems, that means that they feel up to a level but not below that, or brisk reflexes, then we suspect that there is something wrong with the spinal cord. Obviously, we have to bear in mind extreme age groups, more than 50, less than 15, patients presenting with fever or history of cancers. All those are red flags that they have to be addressed, and the patient might need an urgent imaging. This is the picture of the sensation I told you before. So if we have somebody who has compression of the spinal cord around this level, they have normal sensation down to there, but below that, there is loss of sensation. It is very important to classify and clarify when we see a patient in the clinic where the lesion is. This is where I'm always very, very persistent with my medical students and the trainees. They need to know around where the problem is. This will help better and more specific investigation rather than a generic scan. This is the reflexes mechanism, because we said that the spinal cord problem might have increased reflexes. Quite dense slide. The only thing I want you to remember is that the spinal cord, as a superior function, creates some negative feedback, so has a negative effect on the centers of the spinal cord, which are more primitive and they are getting excited very easily. So if a patient has a problem with the spinal cord and there is damage, this negative effect of the spinal cord of the brain stops, and that's an effect we have a quite exciting response with increased jerks in the leg. So you check the reflex in the knee and you have a significant response, which is not a good reflex, it's a bad reflex, and so there's some problem in the spinal cord. This is how a normal MRI scan should look like. The patient has a bit of increased BMI, but apart from that, we can see the spinal cord nicely finishing there. After that, we have the Cauda Equina and lots of brain spinal fluid, cerebrospinal fluid around the nerves, normal discs. And this is the cross-section there. We can see very nicely the nerve roots there and the fluid around them. This is reassuring that there is no significant compression of the nerves in the lumbar spine. This is the picture of the MRI scan of the spinal cord. Again, the main thing to see is the fluid around the spinal cord there, which gives us the peace of mind that we have space so the spinal cord is not in danger. So we can see here the disc, we can see here the back part of the bone, the spinous process, but the spinal cord has enough space to function. And this is an image of a Cauda Equina syndrome. As opposed to the previous imaging, you can see here that the disc has come out. Most of the times is an extruded disc. We remember what we said before. Free disc fragment has come out, still connected. Sometimes is also sequestrated, free disc fragment. Most of the times is the extrusion, rarely of the other categories. And you see here that there is no space for the nerves. We do not see this nice water-like fluid around the nerves because it's completely obliterated by this amount of disc which has come out. On the cross-section, you cannot see anything there from fluid. It's all occupied by the disc. This is a condition called lumbar stenosis. I mention it because sometimes the report says that there is compression of the Cauda Equina, which causes quite a lot of distress to the patient and also general physicians and to people who are not neurosurgeons, and the patient runs to the A&E. This condition very rarely causes Cauda Equina syndrome unless there is a disc prolapse, so some acute change. Otherwise, on its own, it's very rare to cause spinal cord syndrome. Sometimes we hear that people have a non-compatible MRI scan device, such as a pacemaker, and we say, oh, we couldn't scan the patient, delay things. There is no justification of delay. There are other modalities of investigation, and you can do this myelogram. Effectively, it is a CT scan, so it doesn't affect any devices. You inject some dye inside the fluid of the brain, and you check if there is significant compression. You can still do the operation based on this test. The epidural abscess is a different condition than the disc, but can still cause Cauda Equina syndrome in the sense that might compress significantly the nerves or the spinal cord if it's spinal cord compression. And it is an urgent condition, not only from the neurological aspect to decompress the nerves, but also from sepsis perspective, because those patients are sometimes immunocompromised, have significant infection load, and you have to wash it out so you give some more chance to the antibiotics to work and save even the life of the patient, not only the neurology, I say again. This is compression of the spinal cord from a condition like a disc prolapse in the neck. Normally, this is not an urgent pathology, but the patient might present with significant and acute deterioration. In this scenario, I would operate on the patient urgently. If somebody comes with less than 24, 48 hours of acute deterioration, I would probably offer an urgent operation. And this is a true emergency. This is a case of a tumor, a metastatic deposit that has compressed the spinal cord. And I don't know if you can appreciate it because it's a bit of a small image here, but on the cross-section, the spinal cord has been confined to a very small space, like a rim, instead of having all this space for in the middle of the spinal canal. So only this space of the spinal cord, and obviously this is a risk for paralysis. Another cause is discitis. That means infection that might cause some collection of pus around the spinal cord, or direct compression by instability at the area. So because of the disc being gone here, the spine is not stable, and as a result, we have compression of the spinal cord. Another thing we have to be aware of is that sometimes we have a secondary area of infection. So when we follow the patients, we have to focus on both, not just the one, because sometimes this might proceed and we have stabilized this one. This might go worse in the future, and you might miss it on the follow-up imaging. Epidural hematoma can be done by patients who take anticoagulants, blood thinners as we routinely call them, or they might have pathologies that bleed outside the lining of the spinal cord, the dura as we call it. And you see how much compression can be there. This is an urgent condition, has to be dealt with urgently, with removal of bone and washout of the blood. There is little to say about trauma because the history is quite clear, but sometimes there is a sort of insidious onset because the patient doesn't mention a clear trauma. They might have osteoporosis or other pathologies that it's not very clear from the mechanism that have developed, but they might develop severe compression, and it might be cases that they have just pain to start with. And if we don't diagnose very quickly that there is a form of instability, we might miss the situation, we end up with significant spinal cord compression and paralysis. And this is one of the most common problems, the iatrogenic causes. The doctors, in all good intentions, go there to give some space to the nerves, the spinal cord or the lumbar nerves. We wash out at the end, we make sure that everything looks dry and nice, we close, but sometimes the patient bleeds or some fluid is collected there, compression, which might cause problems with bladder and bowel. This might cause Cauda Equina syndrome. It is one of the major reasons of litigation, that the patient was not looked after well after the operation. None of the surgeons would accept easily a complication, but it is a reality and it might happen, and we have to be prepared for that. This is a very rare pathology. It's called spinal dural fistula. It is very rare, but I include in the presentation because I can remember at least 3 cases that came to me as missed opportunities. The patient starts with an insidious onset and indolence course. So it is very difficult to say that we have a clear pathway to identify this condition. But effectively, what's happening in this situation is that an artery communicates directly with a vein in the spinal cord. As a result, the vein has too much pressure, dilates, it might bleed, it might steal blood from the spinal cord. So the patient presents with some symptoms which are not very clear, not significant pain, some walking disturbance, some bladder disturbance. It is difficult to always say that you can work it out, and particularly for a GP or a non-specialist, it's very difficult to suspect this condition. This is how it looks on the MRI scan, and the treatment is quite simple, but the diagnosis is very difficult. It might be several months before this patient is diagnosed, and in this period of time, it is important for the doctor to identify symptoms similar to Cauda Equina syndrome or red flags, which would necessitate the MRI scan to be done earlier, so you can diagnose that indirectly. I don't think that anybody can suspect the dural fistula from the clinical picture. Is difficult and very rare. Why does the topic matter medico-legally? It is one of the commonest and highly valued spinal litigation, the Cauda Equina syndrome and the spinal cord compression. High value litigations with more than 1 million claims common in the medical legal world. It is a life-changing injury, and there are multiple clinicians involved, which creates the difficulties in communication, transferring the patient. So it is sometimes difficult to put in arrangement everything together to avoid the problem of the catastrophe to happen. The cost of the clinical negligence is tripled since 2007, and probably it will go even higher. And this is because we have higher number of cases with negligent claims, high compensation, particularly for neurological injuries. Patients live longer now, so patients who would have less awards before now get more awards now. There is a inevitably rising cost of life and legal and admin cost. And the patients are now more aware, have easier access to information, so they can pursue litigation earlier. So there was a clinical audit a national audit of Cauda Equina syndrome, how we manage it. And they tried to see what we're doing against the criteria set by the SPNS, the Society of British Neurological Surgeons, and the British Association of Spinal Surgeons. And the guidelines from there, effectively, it was do the scan as soon as possible if you suspect Cauda Equina syndrome. That was the bottom line. Do not delay, do not wait. You don't have to transfer the patient to the local services. Do the scan locally, and it has to be undertaken as an emergency over other routine cases. What they found, though, with this audit is that 1 in 4 patients without an MRI scan have been transferred to the spinal unit for an MRI scan. This inevitably causes delays. And if the patient is going to be transferred to the hospital, it has to happen as soon as possible, not after hours, we can't do it and things. It has to happen as soon as possible. We have the networks now, we have communication with other hospitals which do not offer spinal surgery as an emergency, but the diagnosis is important for 2 reasons. The main reason is to avoid the delay of treating the patient who has the Cauda Equina, but also to avoid the referring center to become overwhelmed from all of those cases will end up in one unit trying to be accommodated, scanned, treated. It's going to be very difficult to manage a high volume of patients with similar pathology. They create this very complex pathway, but I'll try to make it a bit easier for everybody. Effectively, it analyzes the patient's journey, starting with the symptoms. Most of the times go to the GP. The GP has to refer to the emergency department if there is suspicion of Cauda Equina. Same there, suspicion of Cauda Equina, MRI scan. This might or might not generate a referral to surgery, and the surgery has to happen in a timely manner. This is the general patient's journey with the Cauda Equina syndrome. In the primary care and the community care, the patients who develop suspicion of Cauda Equina syndrome, they have to be referred to a center which has MRI capability. If they have long-standing symptoms, more than 2 weeks, then this can be assessed through the spinal pathways. And the spinal pathway is this one. If the patient has symptoms with dysuric symptoms more than 2 weeks, they can be seen urgently in the MSK under MSK triage service. Of course, if they develop any deterioration, they have to go down to this route, because if they have any change, if somebody has a little bit of numbness and a little bit of tingling sensation, develops numbness, for example, a change, they have to be told that this is still a significant symptom, and they have to attend the A&E department as soon as possible. In the hospital, in the secondary care, the patient has to be assessed. We have to document all the findings for many reasons. The one is to have even stronger suspicion of Cauda Equina. The other is to have a baseline to know how the patient is after we treat them or after we do any assessment. Bladder scanner or catheter in the bladder, but bladder scanner is the most modern way of measuring how much residual of urine is in the bladder. MRI scan as soon as possible, ideally within 4 hours, and the findings has to be reviewed urgently. You can see here how many steps there are there, and all of them can create a litigation problem, because if the assessment is not proper, if the communication is not proper, the documentation is good, then this might create a problem. The MRI scan is indicated by the symptoms of the patient. So if the patient comes with some symptoms, it doesn't mean that they have Cauda Equina syndrome. The only thing we say there is that this patient needs an MRI scan. The MRI scan will clarify if there is compression of the Cauda Equina or not. So the definition is not only clinical, it's clinico-radiological, the definition. We have to have compression of the Cauda Equina or the spinal cord accordingly. Otherwise, we cannot say that we have the diagnosis of the Cauda Equina. After the imaging, if there is no evidence of compression of the Cauda Equina, but there is some nerve compression, because sometimes patients with significant pain might have some urinary problems, then the patient is not admitted as an emergency, but is referred to the musculoskeletal services for triaging. After that, from there, they can do physiotherapy, injections, or send it to the spinal surgeon to discuss about an operation. If there is nothing there on the scan, then you should not stop. Again, I'm saying we should not scan only the lower back if the patient presents with this picture, because there might be something higher up in the spine. MS patients, spinal cord compression patients, dural fistula patients. So if the patient has symptoms of Cauda Equina syndrome, but nothing in the lumbar spine, we should not discharge the patient without excluding the other things. And if there's confirmation of the Cauda Equina, then the patient should be referred blue lighted to the centers that are doing this surgery, where they keep the patient ill by mouth. Obviously, the patient has to be assessed, document again from beginning the whole history and examination, consent the patient, do our work regarding the spinal registry to see how those patients are doing in the future, catheterization, the patient cannot pass water, and arrange for the theater as soon as possible. I try within 1 hour, as what we say level 1 in the classification system for the emergency conditions. How do the operation? Very quickly, cut the skin in the midline, we expose the bone, we remove the bone, we do a generous decompression there, not like the microdiscectomy, small things there. Generous decompression, make sure the patient has lots of space. And after that, with gentle retraction, we find where the disc is, we remove it, and we allow the nerves to relax. Sometimes we remove large pieces of disc, 2 centimeters. I have removed even bigger than this one. Large pieces of disc can be removed from there and give space to the nerves. Where can we fail? In every step. So in the diagnosis, the GP might say, don't worry, you have sciatica, or you have perhaps some urine infection, arthritis, you have some wear and tear in your back. I have even heard somebody saying, I told to my doctor that I have problems with my bladder, and he said, don't worry, it's from your spine. Obviously, this is not right. On the examination, we might not examine properly, so we don't examine the area as it should be. The examination of the saddle region, I said, it has to be very close to the anus. If we're in the periphery, the patient might have normal sensation. We don't address an anal tone, not necessarily with a finger. There are other examinations, less, not very unpleasant. So, but we have to document the tone, how strong is the contraction there. If we don't complete the examination, how is the patient stand, the balance, we might miss other pathologies. Delayed imaging because we attribute to other conditions. Rogue urgency, we might say the patient can wait for later for an assessment later. Arrange an outpatient MRI scan for somebody who has symptoms of bladder, it's wrong. Even after the diagnosis, and this is where the communication is important, and this might develop, the bad communication might delay the referral, transfer delays for the patient, and theater delays. If you don't communicate effectively, tell them, I have an urgent condition, sometimes even in the theater, they don't understand how important it is. You have to explain to them that, listen, this is a limb emergency situation. It is very, very important to do it as soon as possible. We end up with poor referrals, mixed results, and handover issues change from here and there. Oh, I thought it has happened. I assumed. Never assume anything, assume it has happened, and this might cause many problems. Documentation. People say, normal neurology. This is wrong. It has to be detailed. Power, normal. Even more if you'd like, that examine the muscles in this way, the sensation this way. Poor notes. Sometimes it is embarrassing to see notes from dietitians superior to them, to our doctors, but this might happen. So keeping a good record is very, very important. So regarding the breach of duty of care, the causation, we have to see there when we read through the case if the doctors or the people involved identified the red flags, and did they request the MRI scan in the timely manner. So all those things are important, and if there is any issue there, there is a potential breach of duty of care. And after that, we have to think, does this cause the problem? If the patient has been operated earlier, would it be different? Well, if the patient had established Cauda Equina, probably not. But if it was something that was suspected and became a retention or complete Cauda Equina, then there is a problem there, because there is a causation problem. If the patient was operated earlier, they would have avoided the consequence of developing the full-blown Cauda Equina. Timing is important, and the neurological deficit. What it means is that the biology does not know from time. Time is a human invention, but biology knows from neurological deficit. So this is where the chronic Cauda Equina or the old symptoms come into. If it is stable, it doesn't really matter. Biology knows about stability or instability. So if the patient is stable, it doesn't really matter. The timing is not important there, but the timing is important if the patient is progressing. Then the biology tells you, you have to hurry up. We have here a case of a Cauda Equina syndrome which was missed. Patient went to GP, some symptoms, they were dismissed. The patient arranged some outpatient MRI scan. Delay, the patient developed neurological problems with Cauda Equina, had an urgent MRI scan, showed that there was a clear cause for that, operate, but it was early. And obviously, if the patient had an earlier operation, they would have had a better outcome. Next study is a patient who had spinal cord compression, attributed originally as a low back problem, nothing identified lower back. The patient has had some symptoms which were not very clear, but they had back pain. And despite that, they were mobilized and developed significant neurology. So we have failure here in two things. First of all, diagnosis, but also management. The patient was not immobilized with this condition, which was unstable, end up with a significant neurological deficit with paraplegia. Earlier MRI scan, even in case of cancer condition, can give a better outcome, because cancers can be treated for a long time now. The prostate cancer, lymphomas, conditions that can be treated with long-term chemotherapy, can be treated nicely without any significant problems for the patient. In this study, there was a patient going in and out the GPs for 4 or 5 years, had some scans, small disc. You can see here the fluid around the nerves. At some point, she was seen in the INNEG. She didn't stay for the assessment, not very clear what happened there. She ended up going somewhere abroad and had an urgent operation, and the report said that she had a massive disc prolapse, different picture from what we see here. Obviously, if there is no documentation the patient had pathology beforehand, if had developed any symptoms, relevant symptoms of that, then we cannot say that the patient had Cauda Equina syndrome lost. So in this situation, although the patient had a poor outcome with pain and problems with the bladder, it is defensible case because it is not negligence. So the poor outcome is not always negligence. And this is a very interesting case that was a patient who was seen in the GP surgery with some symptoms, concerning symptoms, but not objective signs. This is where the Bolam test was applied, and the opinion of the medical experts was that, well, if the patient didn't have a clear Cauda Equina picture with numbness, perineal numbness, the rest of it, they didn't need an MRI scan. And it seemed that this gained some preference over the opinion that suspected Cauda equina should need an MRI scan. Again, I'm not sure how the whole discussion went there, but definitely if somebody has suspicion of Cauda equina syndrome, they merit an urgent MRI scan. We need to do an urgent MRI scan and see, because as we saw before, a suspected Cauda equina can stop there and the patient might be free from pain and with normal bladder function for the rest of their lives, as opposed for somebody who has problems. But this claim was dismissed because there was no breach of duty and no causation established in this case. Regarding the medical lessons here, we have to think early and high suspicion from the outset when the patient presents. We have to examine properly, but also document properly. MRI early, and the urgent MRI scan can help us with diagnosis even when it is just suspected. Escalate early. Obviously, the junior doctors have to communicate quickly, effectively, give the urgency to the superiors, and document, always document the picture. Clinical history and examination have to be clearly documented so we know the whole process after that. If I'd like to give a take-home message, the main thing is that could this be Cauda equina syndrome? In this case, if there is question, the suspicion, patient needs to be investigated. Or cord compression, same here, we have to investigate things if there is a progressive neurology. So whoever presents with suspicion of Cauda equina or progressive neurology merits an urgent imaging. Involve the seniors early and document always what we find and the plan. If there is delay in the communication, documentation, management, poor management and documentation, then this might create a claim. And to avoid the claim, it's not just to defend it. The best way is to prevent the patient's harm. If I would like to give you some three important messages is that as we say in stroke, time is brain. Here we say time is spine. The records usually tell us a story. So if we look in the records, we'll see that the patient was seen appropriately or not, documented appropriately or not, and that things have happened in a timely manner to avoid the problem. And also, not every poor outcome or disaster or social problem is medical clinical negligence. So this is the message I would like to give here. This is my presentation. This concludes my presentation, and I don't know if there are any questions. I would be happy to address them.
Thank you, Nikolaos. That was fascinating, and thank you for taking the time to speak with us today. As I mentioned, if you do have any questions, please do pop them in the Q&A function. Before we do move on to the Q&A function, I'd just like to briefly mention next week's webinar. We'll be joined by consultant paediatric neurologist Dr. Anirban Munjabdar for a practical session where you'll learn how paediatric neurological evidence is used to assess long-term outcome, prognosis, and future care needs in complex birth injury claims. We'll send the registration link to that webinar alongside today's recording and slides following today's webinar. So I can't see any questions at the minute, so I'll just begin by
I can see one question there. There is one question. Thank you for it. It's a very good question, really. And thanks for asking me to clarify this question. The question is about sciatica leading to Cauda equina syndrome, or it can cause it. Sciatica means pain in the leg caused by nerve compression in one area of the leg. The most common cause of that is disc protrusion. So answering the question, yes, there is a possibility that unilateral sciatica, so pain in one leg, might show that there is disc protrusion, which might deteriorate to the point of becoming extruded or sequestrated disc that can cause even further the nerves. The space is very small, 2.5 centimeters, something like that, 3 centimeters. This is the space. So a 2 centimeter disc can easily cause complete obliteration of the space. So to answer the question, yes, it might, but it's rare. It is rare to the degree of around 1% of the patients who present with unilateral sciatica might evolve to Cauda Equina syndrome. And this is the reason we do not say for somebody who had sciatica, if there was delay, people say, well, if I had my operation earlier, I would have avoided the Cauda Equina. The answer is no, because an operation might cause this problem. An operation might cause Cauda Equina. So you cannot rush into that trying to prevent something that you might cause. So we address the sciatica as a leg pain problem electively with a discectomy, similar operation with the one you saw, a bit smaller window because smaller discs, not much compression, but on an elective base. That means within the next 3 months, 6 months, with the current situation might be 2 years. Anyway, normally it should be a few months after a patient is in severe pain, we try to treat the patient, but not to avoid Cauda Equina, to treat the leg pain that's caused by the nerve compression.
Thank you very much, Mr. Tzerakis. I can see we've had a couple more come in. So Darnwood has asked, should the age of a patient ever be taken into account?
The white paper clearly said that we should not take the patient's age into account. We have to treat everybody as young fit adults. It does play a role in the sense of if a patient has medical problems which prevent him from having general aesthetic, this is limitation of medicine. Medicine has limitations. And one of the limitations is patients who cannot have the full treatment because of their condition. We can think of alternatives there, but if a patient has Cauda Equina syndrome, generally speaking, I cannot remember when was the last time that I said we cannot operate. Normally, we do suggest operation despite the age of the patient. In elderly patients, the most common scenario is stenosis, narrowing of the space. They might present with a bladder bowel problem, but these are chronic. So normally we treat them as an elective case.
Okay, brilliant. Thank you so much. And we've had another one from Daniel Tubkin. He said, it is my understanding that the window to treat CES successfully is around 48 to 72 hours from estimated onset of symptoms. Do you agree or have any comments?
Yes, this is a very good point. As I said before, biology does not know from numbers. So effectively, if somebody was coming to me on a Friday night with early symptoms, with a large disc and some symptoms or in the perineal, in the saddle region around the anus, I would do it as an urgent case on the same night. Might not be within 1 hour, but would be very, very early, and I would be very worried to leave this patient for the next morning to do the operation, simply because if by the next day the patient has developed full-blown Cauda Equina, it's going to be difficult to justify that we didn't do an operation the nighttime. Very, very difficult to justify that. So although if there are other emergencies and other things, you might use this 48-hour window, generally speaking, the guidelines is about as soon as possible.
Brilliant. Thank you. Well, I can't see any other questions that have come through. So I'd just like to say thank you very much, Mr. Tzerakis, for a very, very insightful talk. It was lovely to hear from you. And thank you to everyone for joining us today. I did just mention earlier that we will be sending a copy of today's recording alongside Mr. Tzerakis' CV and a copy of the slides following this webinar. And I hope everyone found today's session useful, and I look forward to seeing you on future INNEG webinars. Thank you, everyone. Have a lovely afternoon.